forum itself. I'm really glad and privileged to obviously have our lovely Dr. Wande Fafunso, who will be going and talking to us about men's LUTs and how to manage this, how to balance these things out. As you'll see from the screen, makes my life a lot easier. He's a GP partner, prescribing clinical lead in the city in Hackney, as well as working on the NEL SIMP PMO and the NEL MSQG on that front. He's got a wealth of experience, so it'd be lovely to have him on board and to be able to go through this area that we don't tend to go into as much detail on. So it will help us with our education upskilling to a great degree. So without further ado, I'll hand over to Wande.
Thank you so much, and thanks so much for inviting me to your forum. It's a great opportunity to be here and to be able to present. So just a little bit more of a background. So I work as a GP partner at my practice in North London. And actually, before I came here to North London, I used to work in Southeast London. So I do know the south part of London quite well. And in addition to my role as a partner at my practice, I'm also the prescribing clinical lead for City and Hackney. And I sit on the board of the System Prescribing and Medicines Optimization for NEL. And I'm also the deputy chair for our medicine safety and quality group also at NEL. So prescribing is a passion, and I jumped at the opportunity to do this presentation today. So thank you so much. I'm really quite, I think, pleased to hear that you've got this forum, because I don't think we have that in City and Hackney. I think our pharmacists, particularly with the PCN ones, I think they tend to like work in silos. So maybe this is an idea that I will steal and suggest that we have something similar in North East London. So thank you so much again. And I
No
do
problem,
hope,
Wande.
I do hope we do learn quite a bit from this presentation. So essentially, I've been asked to do a presentation on lower urinary tract symptoms and also on BPH. So I'll start with LUTS, with lower urinary tract symptoms. So what is LUTS? Essentially, it's basically an umbrella definition that relates to any symptoms that affect the lower portion of your urinary system. Now, on the right, you can see a pictorial illustration of the urinary tract. And your kidneys are responsible for filtering the body's blood and other waste materials that enter the body, whether that's through food, through drink, or medicine. And the waste then leaves the body as urine. Your bladder has two main functions. So it stores the urine until you're able to go to the toilet, and then it expels the urine when you're able to do so. The bladder would normally hold about up to 500 mils of urine before you feel the urge to pass urine. And even after you feel this urge, we can still hold it a bit more, giving us time to reach the toilet. And then when we're ready to pass, we relax our pelvic floor, contract the bladder, and push the urine out. Obviously, all this happens quite automatically. And usually in people without any problems at all, it's not an issue to pass urine. In terms of how often going to the toilet to pass water is considered normal, up to 6 to 8 times within 24 hours is considered normal. And even if you wake up once at night to pass water, again, that's normal. Sorry, going up to 6 to 8 times in 24 hours, I'm sorry, with one of these occurring at night is considered abnormal. So when you talk about increased frequency of urination or nocturia, this is essentially what we mean. So let's talk a bit about the prevalence, risk factors, and the prognosis. So most elderly men would have at least one lower urinary tract symptoms. And in most people, these symptoms are often mild and not bothersome. So you can see it is essentially a problem of aging, because up to a third of men over 65 years of age would experience some troublesome LUTs at some point. But in most people, it's mild, and like I said, it's not bothersome. It does increase with age. And in terms of the symptoms, in men aged 40 to 44 years, up to 3% of them can experience LUTs. And in men aged 75 years or older, up to 42% of them can experience it. And here in the UK, it is estimated that about 4 million men over the age of 40 will have lower urinary tract symptoms. So for some men, they resolve spontaneously, but for a group of men, it can persist, progress over a period of time, and also become bothersome. So lower urinary tract symptoms can be grouped into essentially two main symptoms. So you've got what we call the storage symptoms, and we've got what we call the voiding symptoms. Now, some include a third category, post-micturition symptoms, as a separate entity. But for the storage symptoms, that would include things like the urgency they complain about, daytime urinary frequency, nocturia, as we mentioned earlier, waking up at night to pass water more than once, urinary incontinence, urge incontinence, and also the feeling of the need to go urinate again after just passing urine. And then the voiding symptoms will include things like hesitancy, slow stream, straining, intermittency, and then sometimes some men may also complain that when they do pass water, it's like the urine is spraying or is splitting. So that can also be categorized as a voiding symptom. And then in terms of the post-micturition symptoms, that's when they complain of the urine dribbling at the end of their wee, and also feeling that their bladder is not completely empty. Now, of course, there can also be a mix of both. So it's not, it's not that patients will present with just storage or just voiding symptoms. They can present with either or even a combination of both. And in fact, up to 50 to 60% of men would actually complain of symptoms in both categories. So what are the causes of LUTS then? And let's talk about that a bit. So they can be caused by any structural abnormality of any part of the lower urinary tract. So we're talking about the bladder neck, the prostate, the urethral sphincter, and the urethra, or even functional abnormalities of any one of those in the urinary tract. Any abnormalities of the peripheral or central nervous system that affect the control of the bladder and the sphincter. Cardiovascular problems, respiratory problems, renal problems, or even endocrine conditions that affect the production of urine. Now, BPH, or sometimes called BPE, which is benign prostatic enlargement, is a common cause of LUTS. Now, I'll come back to that in the second part of the presentation. We'll talk about that in a bit more detail. Your neurological conditions also, like dementia, diabetic neuropathy, can cause lower urinary tract symptoms, infection, as we know, any injury to the urethral area, and even medications. Diuretics, as you know, can cause increased frequency or increased production of urine, and even antimuscarinic agents. And of course, cancer, which we almost also always bear at the back of our mind where we're seeing our patients. And so how do we then assess men who present with suspected lower urinary tract symptoms? So your assessment should really start with you taking a history. So you take a history of their symptoms, the severity of their symptoms, and also asking about any possible underlying causes in the list that we kind of like went through in the previous slide. You're also asking them about the type of symptoms they have, so whether they're storage or voiding, or even a combination of both, the impacts of the symptoms on their quality of life, you're screening for their lifestyle habits. One of the things you can also do, particularly in men who've got bothersome symptoms, is for them to complete what we call a urinary frequency volume chart. And they do that for about 3 days. Now, this is readily available online. And if you go to the Bladder Matters website, you can actually download it. It's really quite useful because what the man does essentially is that for a minimum of 3 days, so 3 days and 3 nights, the patient records anything that they take, anything that they drink, which is the input, and all the urine that they pass, which is the output, including any leakages. And this really helps to assess how what exactly is happening in terms of their lower urinary tract symptoms and how often this is actually going on with that patient. Now, your assessment of that patient is not complete without a physical examination. So we're examining the abdomen. So when we see them in clinic, we're examining the abdomen, we're looking at their external genitalia, we're performing a digital rectal examination to assess the prostate. We're also examining the pelvic area and also their limbs to see if they've got any edema, which can sometimes be a sign of other things going on. If you remember, in one of the things we listed as potential causes, we had talked about cardiovascular problems as as a possible cause of lower urinary tract symptoms. So you're doing a kind of holistic assessment of the patient in order to, as part of that assessment. Reviewing their medication is also important. As we mentioned earlier, diuretics can cause urinary symptoms, so you want to know what the patient is on and whether or not this might be implicated in their presentation. Finally, you also want to exclude any serious causes of LUTS. In this area, we're particularly thinking of things like cancer. And so what investigations do you then carry out? So your investigations should be guided by the symptoms. We've talked about your history and also your examination. You want to do a dipstick test of the urine, checking for blood, glucose to rule out diabetes, protein, which can indicate an underlying renal problem, leukocytes and nitrites, as you know, to rule out a UTI. Blood tests in terms of use and needs are very important because, first of all, you can use that to have a sort of like a baseline, but also using it is important to check, particularly if the patient has a history of recurrent UTIs or kidney stones, or even while you're examining the patient, if you feel the patient has a palpable bladder, you want to make sure there isn't any obstruction that potentially is causing a sort of a damming of the urine into the bladder and also into the kidneys, causing hydronephrosis. The PSA, I'll talk about that in my next slide, can also be offered to the patient if it's appropriate. And in terms of the management of lower urinary tract symptoms, the management is essentially divided into those men whose symptoms are bothersome and those men in whose the symptoms are mild or not bothersome. And that would give you a guide as to how to manage these patients. So I thought I'll do a really quick slide on PSA testing because I can anticipate that some people may have questions around that or, in terms of what the guidance is. Now, it really can be quite confusing, but I'll try and, I guess, in a sense, simplify it in a way that we might be able to, I guess, retain and understand. So the PSA is a test that can help diagnose prostate problems. But before you actually offer a PSA test to a patient, do make sure that you've given them appropriate information to enable that patient to make an informed choice about testing. Because PSA levels can be raised. People, I think, sometimes think a raised PSA automatically means something serious like cancer. But it can also be raised in a UTI, even in BPH, which, as we know, is a benign condition, in an inflammation of the prostate, and of course in prostate cancer. So it's not just prostate cancer that would elevate the PSA levels. But before the man actually has the PSA test, they should not have had any intercourse or anal sex in the previous 48 hours. They shouldn't have had any vigorous exercise, for example, cycling, in the previous 48 hours as well. They shouldn't have had any urological interventions such as prostate biopsy in the previous 6 weeks to testing. And of course, they shouldn't have any active UTI. So which is one of the reasons why you check the urine, just to make sure they don't have a UTI. So all of this is what you need to make sure you've kind of like ruled out before you send the man for a PSA test. Now, the reason why PSA testing is not offered as a population screening test is because it's not a very specific and sensitive test for prostate cancer. So, in fact, about 3 in 4 men with raised PSA level, i.e. greater or equal to 3 nanograms per ml, will not have cancer, and a small proportion of men who have a low PSA level will later be found to have prostate cancer. So it's very important to make sure that you're discussing the pros and cons of PSA testing with patients and to offer it only when appropriate. Now, my next slide will show you what the PSA reference range is for the different age groups. And if a man in any of these age cohorts has an elevated PSA above the reference range for their age group, then you should really be considering referring that patient, especially if they have symptoms, on the suspected cancer pathway referral to rule out prostate cancer. So let's now go back to how we then manage men with lower urinary tract symptoms. I'll start off with those men who have mild symptoms. So if the symptoms are mild and not bothersome, you basically offer them conservative management and you're offering tailored information advice to that patient. Now, that information and advice could include advising them to reduce their fluid intake at specific times. So, for example, maybe before they go out in public, before they go to bed at night, to reduce their urinary frequency when most inconvenient, and that the fluid intake should they can drink tea, coffee, and alcohol in moderation, but you don't want them having excessive intake of caffeinated drinks because that would make them produce more urine and could potentially make their symptoms worse. So we're not asking them to, limit excessively their intake of this thing because that could then increase the risk of complications because they could then become dehydrated and then have a UTI, for example. But you're advising them to make sure that they take these things in moderation. And if they're taking fizzy drinks, for example, if they take large volumes of those, it can cause rapid filling of their bladder, leading to frequency and urgency. So they should actually try and space their drinks evenly throughout the day. It's important to also advise them to avoid constipation because a full bowel will affect the bladder function. They can also be taught what we call bladder training, where is a process where they kind of like train their bladder to hold a greater volume of urine for a longer period of time. And one of the things you can advise the patient on how to do this is if they feel or when they feel the urge to pass urine, to kind of like play, in a sense, a mind game with themselves. So, and to tell themselves, well, no, I actually don't feel like I'm going to go. And to distract themselves for a few minutes from the time they get the first urge. If they are able to progressively extend the period of time from when they do get the urge to when they go to the toilet, if they're doing this regularly over a period of time, for example, over a week or 2 weeks, they will then find out that they're actually able to delay that urge, to such a time as when they're then able to go and pass urine. So that, in a sense, is what bladder training is about. The other thing you can also advise them to do are pelvic floor exercises. So the pelvic floor exercises strengthen the perineal muscles, giving a bit more support to the bladder, and also trying to ease those lower urinary tract symptoms they might be complaining of. For those men who have bothersome symptoms, and we define those as those men whose symptoms are moderate to severe, you have to offer them drug treatment as a first line, particularly if the conservative management has failed or is inappropriate. And your first line medication that you're offering them is an alpha blocker. The alpha blockers, as we know, if you remember your pharmacology, they actually work by relaxing the smooth muscle of the bladder neck and the prostate. You've got your older alpha blockers, which are the less what we call uroselective ones. So your doxazothane and your terazothane. But because of their side effect profile, that can sometimes limit their use in the management of lower urinary tract symptoms. But any man that you're starting on the alpha blocker, you need to review them 4 to 6 weeks after starting, and then after every sort of 6 to 12 months. And during your review, you're reassessing the symptoms to see if it's getting better or maybe no change at all, the impact on their quality of life. I'll talk about the International Prostate Scoring System a bit later, but you can also use that to try and assess not only for the quality of life um, uh, for that patient, but also in terms of actually the grading of the symptoms. But we'll talk about that a bit later. Your review is also assessing for any adverse effect of treatment for your patient as well. So, as we said, first line treatment will be your alpha blocker, particularly if the man has storage symptoms. But even if they have voiding symptoms that persist after treatment with an alpha blocker alone, you can consider adding an antimuscarinic agent. So here we're talking about things like oxybutynin, particularly the immediate release oxybutynin, your tolterodine immediate release, or darifenacin. The way anticholinergics work is that they block the action of the acetylcholine that's released to the parasympathetic nervous system. The acetylcholine usually sends signals to your brain to trigger bladder contractions. But what happens with the anti-muscarinics is they then actually block that system so that the man doesn't feel that sort of need to urinate. If the first line drug is not effective, then you can offer an alternative drug. So, for example, if your antimuscarinics are contraindicated, they're not tolerated or not effective, then you can offer mirabegron. So, as usual, review the patient every 4 to 6 weeks until their symptoms are stable, then every 6 to 12 months. You're assessing their symptoms again, the quality of life, or for any adverse effects to their treatment, or whether or not they actually do need to continue treatment. So for men who are considered to be what we call at risk of progression, i.e. those men with severe symptoms, older men, so particularly men over the age of 65, or men who have a prostate size that's estimated to be larger than 30 grams, or when you do check their PSA, if the PSA is greater than 1.4 nanogram per ml, those set of men, you should be offering a 5-alpha reductase inhibitor, such as finasteride or dutasteride. And the way they work is by decreasing the size of the prostate by inhibiting the conversion of your testosterone to the active metabolite dihydrotestosterone. But you can also, in fact, consider offering a combination of both an alpha blocker and a 5-alpha reductase inhibitor to men with moderate to severe LUTS and also at a significant risk of progression. And there was data from a 4-year study a couple of years ago that in fact showed that that combination therapy in those men with significant risk factors for progression was found to be more effective than monotherapy with either your alpha blocker alone or just the 5-alpha reductase inhibitor, and actually did reduce the any possibility for surgery over that period of time. So there is a case for offering combination therapy to this man. But please always remember that if treatments fail, if the symptoms persist or become more bothersome despite your intervention, or if at any time they develop any new or worrying symptoms, then you're wanting to refer that patient for specialist urological assessment. So I don't know if we have any questions so far before I go into the next part of the presentation, which is BPH. I can't see
None at this moment, Wanda. If there's anything
Okay,
that comes up that's pertinent, I'll give you a shout in between. Don't worry.
brilliant, thank you. Okay, so let's go on to BPH then. So as the name implies, it's benign prostatic hyperplasia. It's a benign enlargement of the prostate gland, but it's actually a histological diagnosis. Of course, clinically they present with symptoms, but it is a histological diagnosis. And what you find when you do a histology of the prostate with BPH is that there is an enlargement of the smooth muscle of the prostate, as well as the glandular tissue of the prostate. And when this happens, the enlarged prostate essentially causes bladder outlet obstruction and lower urinary tract symptoms, as you can see from this slide. So the prostate gland in men goes through two main growth periods as the man ages. So the first is in early puberty when it doubles in size. And then the second begins, I think, around the age of 25 and continues throughout most of the man's life. Now, in many men, that doesn't become an issue. But when the prostate then becomes large enough to cause problems, that's when you have your BPH, and they then present to you with the symptoms. We don't really know the cause of BPH, but we do know that it increases with age. So aging is a risk factor. The long-term exposure to testosterone, particularly the active metabolite dihydrotestosterone, are the most significant contributors to the condition. So it's very rare in men under the age of 40. By 60 years of age, about 60% of men would have or experience BPH. And by 85 years, almost 90% of men would have BPH. So in terms of the risk factors, we've talked about age, genetics, and also geography in some studies have been shown to be what we call non-modifiable risk factors. So you can't do anything about these risk factors essentially. But the modifiable ones would be things like endocrine conditions like metabolic syndrome, diabetes, hormones. So bodybuilders who take like testosterone, etc. Diet has also been shown to have a link to BPH, inflammation in the prostate, and lack of physical activity. In fact, there isn't a direct relationship between the severity of the symptoms when they present and the size of the prostate. So, because you would think that, well, the larger the prostate is, then the more severe the symptoms should be. But in fact, men with even smaller size prostates can present with LUTS, and those with really enlarged prostate may actually have no symptoms at all. But it's
Well,
also
I've had
very,
a question come through to me
yes,
directly, if you don't mind me asking.
sure.
Um, if a patient has a significantly enlarged prostate, so has BPH, what is the risk of them potentially contracting something like prostate cancer? Is there a link between the two?
No, and so that's actually in the slide as well. So there isn't a link. And so men with BPH are no more likely than men without BPH to develop prostate cancer. So there isn't a link there. And that's very important to know, because I think a lot of men with BPH sort of worry that actually BPH is a precursor to developing prostate cancer. So BPH is not a carcinoma in situ, for example. It's a completely different etiology, and there isn't any link there. I hope that answers the question. Can you hear me?
Yes, I put my thumb up. I didn't know if you could see me, but yes, perfect. Thank
Oh
you
no,
so, so
sorry, I
much.
couldn't
I
see.
think I
Okay.
think that's a big concern, especially when we're doing medication reviews as pharmacists or pharmacy technicians and we're worrying about it. It
Yeah.
is a concern that we're thinking, is there a link? Is there something else I should be worrying about? So thank you for that confirmation.
Yeah, no, and please do reassure your patients to that effect as well. Okay, so how do they present and what symptoms do they have? So they do have their lower urinary tract symptoms, like we said. So the voiding symptoms, also sometimes termed as obstructive symptoms, or the storage symptoms, as we listed in the first part of the presentation, also known as irritative symptoms. Now, if you've ever worked in A&E, like I have, you do find that, in fact, in quite a few patients, they can present as with acute urinary retention as the first presenting symptom for BPH. And other symptoms and presentation could include things like renal impairment. So you do their blood test and you, for example, see that they've got an element of chronic kidney disease or chronic renal impairment, and you know that that patient doesn't have any risk factors for CKD. They can present with hematuria. Sometimes they present with what they call like Coca-Cola colored urine. They can also present with recurrent UTI. So if a man is coming to you with any of these symptoms, you need to be assessing them for possible prostate symptoms. So as the as the prostate enlarges, what happens is it presses against the urethra. The bladder wall then becomes thicker, and over time, the bladder may weaken and then lose the ability to empty fully. So the urine then remains in the bladder, which then causes all the symptoms. So, your voiding symptoms, your storage symptoms, your recurrent UTIs, for example, CKD or even AKI, so acute kidney injury, especially when they present in acute retention. So I've mentioned earlier about the International Prostate Symptom Score. So while it's not a diagnostic tool, it does help and allow you to grade the lots as either mild, moderate, or severe. And so when we're talking, for example, about when you're reviewing the patient after 4 to 6 weeks of starting treatment and after every 6 to 12 months, it's actually very, very useful to help you in assessing the impact of the urinary symptoms on their quality of life, and also to monitor the progress and the response to treatment. So if this is something you've not been aware of previously, you haven't used before, I would really recommend actually including this in your practice. And this is what it looks like. So it's based on the answers to 7 questions concerning urinary symptoms. Each question is assigned points from 0 to 5, indicating increasing severity of that particular symptom. The total score can therefore range from 0 to 35, so from asymptomatic to very symptomatic. And generally 0 to 7 is considered mildly symptomatic, 8 to 19 moderately symptomatic, and then 20 to 35 is severely symptomatic. So it's really, really useful and very helpful. So I do this a lot when I'm seeing my patients, because it's like I said, it gives you a sense and idea of how they're not only how they're progressing in terms of their treatment, but also in terms of what the impact is having on their quality of life. So your assessment, as we said also previously when we were talking about lots, starts with you taking a history. History is very important. I've talked about the IPSS, which can use as a baseline your initial assessment to assess the severity and the impacts on their activities of daily living. We talked about some men, for example, presenting either acute retention or even chronic retention. So your abdominal examination is very important to see if they've got like a palpable bladder. You also want to be examining the external genitalia and doing a digital rectal examination. So that's when you assess the size of the prostate, the shape of the prostate, and the consistency of the prostate. In BPH, what tends to happen, and I know, of course, I'm presenting to the pharmacist, so you probably won't be doing, any DREs. I wouldn't have thought. But what we're essentially looking for when we're examining the prostate with a rectal examination to confirm that it's BPH is a smooth, firm, and elastic enlargement of the prostate. What you feel in cancer is the opposite. So in prostate cancer, the prostate feels quite hard. You get lots of nodules, and it feels irregular. And also, there is something in the prostate we call the median sulcus. So that's kind of like a ridge in between the two halves of the prostate. You can feel that ridge quite smooth and nice in a non-malignant prostate. But in prostate cancer, that ridge is completely gone. You can't feel it because of the irregularity of the prostate. So it's always very important, and we always do this as part of our assessment.
And I think someone has said to me once, it feels like a walnut almost. is what you're
Precisely.
kind of trying to go for. Another follow-on question that I think people are a little bit shy to put in the chat by the looks of it. A follow-on question is in terms of BPH, how often should they be asking for someone to get a DRE or a digital rectal examination? Because we do it before to confirm the diagnosis. Should they be getting it done every few years at all, at any particular point?
That's a really good question, actually. So, of course, you do your DRE and every man with any prostate symptoms, with any lower urinary tract symptoms, really should be getting a DRE done because you want that, first of all, as a baseline. Secondly, to actually confirm that this is BPH and not cancer, because that's a completely different pathway. And thirdly, if and when, and that's why I said this is a really good point, actually, a good question, rather. If their symptoms do change at any time. So, for example, just as an illustration, a man had presented with, urinary frequency and urgency as his main symptoms. You've been managing him, and then at some point, he then has new symptoms. For example, he starts to complain of hematuria. Then you want to do a DRE again at that point, just to make sure, well, actually, nothing's changed. Or in fact, something has changed. The prostate that previously felt smooth and firm is now hard and irregular. So it's only really at those points you need to do your DRS. You don't need to do the DRS every single time the man comes back for an assessment, and you don't need to do the DRE every single time you see the patient. You definitely do it at the first point of contact when you're assessing that patient, or if things change at any point to confirm that the diagnosis still is the same or something's changed and you need to change tack.
So, for example, if a patient decided that, oh, the medication stopped working, that would be a bit of a red flag, thinking, okay, I need to do a DRE potentially, however many years down the line, potentially. That may be something we want to consider.
Yes, absolutely. So any change at all. So I mean, in terms of the medication stopping working, I think I would probably, if I am convinced that the patient's obviously got BPH, so of course, again, I think I was going to come to it in my next slide. But one of the things you do as part of your investigations is a scan.
Yes.
So your scan will assess the prostate size, will look at the prostate, and of course your scan would show anything that's suspicious. So if I have a quite recent scan, so say for example, at the initial time of my assessment, I've sent the patient for, I've done my DRE was fine, sent them for a scan was fine. They then come back a few months later and say, well, actually, the medication is no longer working. I think what I'll be probably thinking of at that point is more in terms of, well, actually, is this man, if you refer to one of my previous slides, is he now progressing in
Mm.
terms of the symptoms, and do we then need to consider a second agent or a combination therapy? If I already have those kind of assurances from the DRE and the scan, I mean, yes, of course, if he's in my consulting room, it's a quick examination, I would do one. But I guess you probably would want to do it when they complain of a change in their symptoms. You definitely want to do it then, rather than just saying the medication is no longer working, if you see what I mean.
Yeah.
If by medication no longer working, they mean they're now developing new symptoms, then yes, you want to do the DRE, absolutely.
Perfect. I had another question. So they're now coming through. So in terms of caffeine, because caffeine's always a contingent issue on that front, is decaf coffee okay, or is it the coffee itself that increases the frequency itself?
No, it's the caffeine. So yes, so decaf coffee is okay.
Perfect. And that would be the same with decaf tea as well, then I'd take it as well. Because we're all about giving decaf these days to everybody.
Correct. Yes. And as long, and I mean, with this thing again, as long as they take it in moderation, so even if they want to take caffeinated drinks, I mean, of course, they probably need to be aware that, they might, notice a slight, I guess, you know, slightly more bothersome symptoms if they're taking it excessively. But you just don't want to say to people, well, completely stop taking coffee, completely stop taking caffeine or tea. They just need to be, I think, sensible in terms of their intake.
Absolutely. I think the key thing for me is that you want people to still have a good quality of life. So even limiting time-wise, if the nighttime symptoms are more troublesome and that's what's causing them more issues, limiting it before 7 p.m. is something that I've had a chat with the continence team before, and they've said quite clearly that as long as it's before 7 p.m. and they're going and drinking in moderation, this should be okay on that front. It
Yeah,
helps to minimize the evening symptoms.
That's correct. And in fact, that's what we do advise the patient. So normally, I mean, I can go a little bit earlier than that and say, well, actually, really, no caffeinated drinks after 6 p.m., to be honest, because you then do find that you're sort of waking up even more frequent at night to pass water, etc. So yes, so those are some of the, I guess, simple lifestyle advice and tailored advice that you can give to patients that can sometimes make a difference to their quality of life as well.
Perfect. No, all the questions are done. You feel free to carry on.
Excellent. Yeah, so as I was saying, so your investigations will include things like your urinalysis, you're checking for blood, you want to rule out UTI. Does the man have diabetes? Sometimes they actually pick them up that way as the initial presentation. Your urine culture to exclude any infections, your UTIs, for example, you want to make sure that they don't have a UTI that needs treatment, and maybe actually that's what's causing their symptoms. You're using these for the assessment of their renal function and also as your baseline. PSA we've already talked about, and like I said earlier, that can be raised not only in BPH, but also other conditions like inflammation of the prostate and prostate cancer. And as I was mentioning earlier as well, your ultrasound scan. So we would usually send the patient for what we call a KUB plus P. Now, in some areas, if you send the patient for a renal scan, they would only do the kidneys, ureters, and bladder, which doesn't make sense to me because actually the prostate is part of the renal tract, really, or urinary tract. But in some places, you actually have to specify and include the plus P so that they can not only obviously assess the bladder, but also the prostate size. In addition to checking if they've got any enlargement of their kidneys, for example. So it might be useful, and I think for me as a standard, because I do sometimes also locum in other areas, when I'm requesting my ultrasound scan for a patient whom I suspect might have prostate issues, I always just, as a matter of routine, include KUB plus P, because you don't want them to have a scan and you only get the kidneys, the ureters, and the blood and the prostate, and then have to send them again for another scan, and you're just, exposing that patient to even more radiation. So I know you're a pharmacist. This is the bit that probably really, really interests you. So in general, we offer medical therapy as the first line management for patients with bothersome or moderate to severe symptoms of BPH. Similarly, as we're discussing for lower urinary tract symptoms in general, your alpha blocker will be your initial therapy, particularly for men with moderate to severe symptoms. And we've talked about the different alpha blockers that we have, which I guess do have similar efficacy, but differences lie particularly within things like this side effects profile. So you need to counsel the patient about some of the common side effects with this drug. So the dizziness, the tiredness, and even premature ejaculation. Normally, once you start the alpha blocker, again, if you remember because of the way they work, the patient should really see an improvement in the symptoms within days and a full response after about 4 to 6 weeks. So and I'm sure you probably get this all the time for some patients, and I see this a lot. When you start a patient on the medication, going back to that bit about well, it's not working, and they come back to you a week or two later. Well, it's not working. I'm still waking up several times at night to pass water, etc. I normally just say to my patient, and this should really form part of your medication counseling right at the beginning. Because one of the things I've noticed is if you do a really good medication counseling at the beginning, then the patients are one not only know what you're prescribing the medicine for, how it's meant to work, what it's meant to do, how long before they start seeing any change, and of course, what to watch out for in terms of side effects or any worrying side effects to keep an eye out for. So I would usually tell my patient that they probably need to give the medication at least a month or 4 to 6 weeks, and then we can review at that point. So I make it clear to them, well, there probably really isn't any point coming back to me 2 weeks after starting to say it's not working. Let's see you in a month's time, and then we can assess at that point. So it's very important to make sure that you're having this quite detailed conversation with the patients at the beginning when you're starting them or discussing the medication with them. So your long-acting alpha blockers, alpha-1 blockers are your terazosin and doxazosin. Terazosin and doxazosin, because of what we call the first dose effect, so with regards to hypertension and syncope, you normally want to sort of like gradually titrate those upwards. Alphazosin is a shorter acting alpha-1 blocker, usually available as a modified release formulation. Now, alpha-zosine, doxazosin, and terazosin, they are associated with a lower risk of ejaculatory problems. And so in your younger, maybe more sexually active men, you might want to, they might be actually preferable to start them in that cohort of patients. The alpha blockers themselves are associated with something we call floppy iris syndrome. And in men who are going for cataract surgery, this can be a huge problem. And the risk of this syndrome was found to be highest with tamsulosin. So if you're starting this medication in particular, you probably want to be checking with that patient that they're not, booked for any eye surgery that's imminent or at some point, because that's something that a lot of people don't know about. But actually, we do get this from our ophthalmologists to say, look, when you're referring patients for cataract surgery, always make sure that you look at the medication that you're taking. In the same way, for example, that some drugs you probably want to avoid them in patients with certain types of glaucoma because it can precipitate acute angle closure glaucoma when they're doing surgery. So tamsulosin, patients should be asked about any potential eye surgery prior to initiating therapy. And so this gives you your options, the primary options. So the terazosin, as we mentioned, talking about earlier, you start with 1 milligram once daily initially, and then you can increase that gradually according to the response. The maximum dose is 20 milligrams per day. You give that in 2 divided doses. Or if you're going for the doxazosin option for BPH, you start with 1 milligram immediate release once daily initially. Increase that again gradually according to the response. Maximum dose of 8 milligrams per day. If you're going for the extended release option, you want to start with a 4 milligram dose once daily initially, and then increasing that gradually according to the response up to a maximum of 8 milligrams per day as well. Or alpha-zosine, which is 10 milligram orally once daily in the extended release, that's the only dose. Tamsulosin, 400 micrograms once daily initially. Gradually you can go up to 800 micrograms. I think in practice we generally don't. Most men would probably find that the 400 micrograms does work quite well for them, but you can go up to the maximum of 800 micrograms per day. Or silodosin, which you can give as an 8 milligram dose once daily. The other thing to be aware of is that men taking alpha blockers have been shown to have significantly increased risk of falling and fracture. So when, as part of your assessment for these patients, you probably want to be doing a falls assessment, or at least assessing for their risk of falls and fractures and counseling them about this. There's also increased risk with the alpha blockers with hypertension and head trauma. And these are just things you need to be aware of. And of course, if you find that you have patients who are significantly at risk of any of these, then you want to be really, really counseling them about the medication, or maybe, in fact, thinking about another option in terms of what to start them on initially. So for men with BPH who have prostates greater than 30 grams on imaging, so really quite large or larger prostates, if they have a PSA greater than 1.5, or when you do your DRE, the prostate actually does really feel quite large, you can consider the 5-alpha reductase inhibitors as initial monotherapy for this patient. So starting them on the 5-alpha reductase inhibitors rather than your alpha blockers if they meet this criteria. This is because the 5-alpha reductase inhibitors have been shown to be effective in reducing the prostate size in those patients with larger prostates, and therefore reducing that risk, the short-term risk for acute urinary retention and surgery as a result of that. They have quite a slow onset of action. So again, when we talk about counseling patients, this is something to also make them aware of. particularly, it's not working for me after 1 week type patients, because they take several months to actually improve their symptoms. So these are the patients that you're wanting to, when you're doing your review, sort of like 6 months down the line, to actually assess how they've gone, how they're doing at that point. You probably wouldn't see as quite an improvement within weeks as you would with the alpha blockers, with these ones. And so they are much more suitable for longer term treatment. So men with BPH treated with an alpha blocker alone, or in combination with a 5-alpha reductase inhibitor, may also be at increased risk of heart failure compared with men who aren't taking any medication at all. And the non-selective alpha blockers appear to be associated with higher risk of heart failure than the selective ones. So again, when we're talking about your medication review, your counseling, your assessment of the patient, and when we talk about taking the history, etc., these are things you need to be checking and assessing for in that patient, and then making your decision, of course, alongside the patient about what is more appropriate to commence or to initiate in that patient. Now, with the 5-alpha reductase inhibitors particularly, in about 5 to 10% of patients, they can experience sexual dysfunction. So either decreased libido, premature ejaculation, erectile dysfunction, or breast enlargement gynecomastia. And finasteride in particular is associated with psychiatric side effects, and the sexual side effects that we talked about earlier, particularly things like depression and suicidal thoughts. So if you're starting, I guess, well, any man in general, but certainly for the younger ones, I guess those in their late 40s, early 50s, you probably want to be counseling them about this potential side effects. Now, thankfully, they're not that common, but I think these are the ones you want to make sure that the patients are aware of and what they need to do if they start experiencing of those symptoms. If I have a patient with either an active or even a past medical history of depression or any mental health illness, particularly a severe mental illness, I certainly wouldn't be starting them on finasteride. Now, in terms of your doses, 5 milligram orally once daily for your finasteride, or dutasteride, you can go for 0.5 milligram orally once daily, and those really are the primary options that you have. You can consider the phosphodiesterase 5 inhibitors for patients with BPH and erectile dysfunction, or you can actually consider it as a second-line option. But the only approved PDE5 inhibitor for patients with comorbid BPH and erectile dysfunction is tadalafil. And the tadalafil dose you commence them on is 5 milligram once daily. So the way the PDE5 inhibitors work, obviously, is to block the PDE5 enzyme to prevent it from working. And so that inhibition, what it does is it relaxes the blood vessels and increases blood flow to the penis. There is something called the International Index of Erectile Function, IIEF. It's a questionnaire. So it's a validated sort of self-administered and multidimensional tool that has been found useful in the clinical assessment of erectile dysfunction. And you can actually find this on the British Association of Urological Surgeons website. And I think I would really recommend it. So even if you're saying men, even if it's not related to BPH, but men who are coming to you with like ED symptoms, it's a really useful tool that helps you to actually assess the impact the erectile dysfunction is having on them, and in a sense how to kind of like differentiate and grade it. So it's called the IIEF, and if you just type that in or go into the BAUS website, so the British Association of Urological Surgeons, you can find it there. So maybe something for you to have in your toolkit as well, in addition to the IPSS, when you're assessing or dealing with patients with lower urinary tract symptoms. Now, men with BPH and storage symptoms, if you remember to the slide on LUTS, for these patients, you can also consider anticholinergic therapy. And the options you have, if you are going down that route, would be your tolterodine, which is that either as the immediate release 2 milligrams orally twice daily, or the extended release 4 milligrams orally once daily. Or you could go for fesoterodine, 4 to 8 milligrams orally once daily, or oxybutynin. You can see the doses there and how you actually start that and titrate that, or sulfasalazine. Now, obviously, as a prescribing clinical lead, I know that different areas have their like their formularies. So you probably also need to make sure that whatever you're starting the patient on is in line with your formulary recommendations. But these are the options you have. And if there are no sort of like restrictions in terms of like prescribing, then you could go for any of these and commence that patient on it. The anticholinergic associated adverse events would include things like dry eyes, dry mouth, constipation, dizziness, etc. So again, you want to be counseling those patients to be aware of these symptoms. Potential side effects. Now, previously, and a few years ago, there were concerns over the risk of worsening bladder retention, particularly with this group of drugs. But subsequent studies have shown these concerns to be unfounded. However, there are studies that suggest that there is an increased risk of dementia associated with anticholinergics. And for the very sort of, I guess, older patients, maybe my patients in my 80s or 70s even, patients who may be at risk of falls, patients who might have like cognitive issues, etc. I might be a little bit, hesitant about starting them on anticholinergics and maybe look for another option. So this is where, taking a really good history, looking at the patient's records, counseling the patients, assessing the patient, this is where it really comes in. And I think one of the things I do like about my pharmacist and the pharmacists that I work with, and pharmacists in general actually, is that pharmacists have been really, really detailed and quite thorough when it comes to medication. So, just do what you're doing, what you would do normally, and make sure that you're assessing that patient thoroughly before deciding on what you would be offering that patient. And of course, it's a joint thing with the patient in terms of the therapy and medication. So combination therapy, usually second line, can be considered for patients with moderate or severe symptoms, particularly those who are at risk of progression. I think we've mentioned that before. Also, patients who have inadequate symptom control, or patients whose symptoms are progressing on monotherapy. And there was one systematic review that reported that a combination therapy with a 5-alpha reductase inhibitor as well as an alpha blocker actually show greater than a 4-point improvement. So when you look at the IPSS score at the time of starting, and then later on with that combination, that it showed a 4-point improvement score, and therefore that combination therapy of the 5-alpha reductase and the alpha blocker was significantly better than monotherapy. And there's another study that also showed that treatment with tamsulosin and dutasteride for up to 4 years did reduce the risk of clinical progression, acute retention, and the need for surgery. So anticholinergic therapy in combination with an alpha blocker can be suitable for men with predominantly steroid symptoms. Your beta-3 adrenergic agonists like your mirabegron or your vibegron, you can offer those also in combination with an alpha blocker to BPH patients with predominantly moderate to severe storage symptoms. And another randomized controlled trial actually showed that combination therapy with tamsulosin and mirabegron actually improved storage symptoms in men with BPH who had persistent symptoms despite monotherapy. So I think that there's something to say for actually considering combination therapy, particularly when they do have quite moderate or severe symptoms. So my final slide is just a really quick one about surgical management. I'm not going to go into that in a bit more detail. Obviously, if it's really impacting the man's quality of life, the symptoms are not responding to medical management, patients with complications, these are indications for surgery. And I've just listed there some of the surgical options that are available nowadays. So you have a TRP, which is transurethral resection of the prostate, which is the most common surgical management. You've got your transurethral vaporization of the prostate. You've got endoscopic enucleation of the prostate. And minimally invasive surgery. So these are some of these procedures are quite new and recent ones. And of course, you probably would have also heard of robots now being used to do simple prostatectomies in urological surgery. So that is the end of the presentation. I really do hope you've enjoyed it and have learned a thing or two from it. And if there are any other additional questions, I'm happy to take those.
Absolutely. Thank you so, so much. And I was going to say, I've definitely picked up a couple of bits and bobs on that front along the way, and you're getting a lot of round of applause coming through. So thank you so, so much for that presentation. Are there any other questions for one day at all? Feel free to obviously pop them in the chat. If you feel shy, you can send them to me on WhatsApp because that's what I seem to be getting on that front. This is one thing after another on that front, keeping them there. But I've got people going and saying, great presentation. Thank you so much, one day.
Thank you so much for having me. It's been fantastic presenting to the team.
So I think that's the key thing for me. I think the presentation is amazing. And I think we've got a lot of thank yous coming through. And if quite a few people saying they haven't been able to make it, but they'd like the recording of this, Nisha, on that front. So I think this is actually really, really helpful on that front, and really, really helpful. Funnily enough, actually, what I've seen when I've been getting getting a lot of ultrasound reports coming through, they're actually going and saying to me, start people on finasteride first line because of the size of the prostate, which was a new thing for me. Is there any benefit for those particular patients on being on finasteride and then considering the tamsulosin at any point, or would you go straight for the finasteride?
Sorry, say that again. They're asking you to stop the finasteride because,
No, they asked me to start finasteride
or to
first
start, yeah.
line rather than even considering obviously the tamsulosin. Is there a place for that person to be on tamsulosin at any point, or would we just simply keep them on just the finasteride going forward?
Yeah, so that's interesting. So I haven't really come across that. So I would usually start them on tamsulosin.
Mm.
I mean, I guess practice differs in different areas, and if there's any particular reason why they're asking you to start them on finasteride, then it might be worth just exploring with them, why they've gone straight to that rather than the tamsulosin, or actually why they haven't considered a combination of the tamsulosin and the finasteride, and just the finasteride as immunotherapy. So I would want to sort of explore that a bit more, but that's not usual or standard practice. And maybe that particular urologist has had anecdotal sort of experience in terms of working that way or making that suggestion, and that's why they're advising you to do that. But no, I would want to explore more.
Perfect. Thank you. The other thing I was going to say as well is just make sure if you're going to go down the route of going and putting them on a combination, please make sure you prescribe them separately. You're going to be blowing your drug budgets if you prescribe it as the brand on that front, because they're about, I think it's about 30, 40 pounds for the brand compared to if you prescribe them individually, it's about £3, £4. It's about £10 more expensive, 10 times more expensive on that front. So please make sure you prescribe generically to make life easier
Yeah.
on that front. Obviously, if concordance compliance is an issue and you've got other issues, there's something else to be considered for patient factors. But if we can, please do make sure you're prescribing generically as per SAPS and the guidelines itself. But I think that's been really, really helpful on that front. And the other thing I was actually going to say, something that I've learned from experience in terms of caffeine, people really go about decaf and tea. Actually, chocolate is actually quite a rich source of caffeine as well. So please make sure people aren't going eating chocolate. We'll stop the coffee and the tea about 6, 7 o'clock. But if someone's eating chocolate until crazy o'clock, that will also go and cause a need to go to the toilet overnight. I was going to say personal experience on that one, but there you go. That's something for everyone to think about over Christmas on that front. I don't see any other questions coming through, but thank you ever so much, Wanda. It's been really, really helpful. And we may get you to come back for a follow-up for other questions and queries if you're able to in the future, if that's okay.
Yeah, no, that's fine, and it's been a pleasure. Thank you so much for having me. I'm also
No
quite
problem.
happy to share my slides, and yes, please feel
Perfect.
free
Thank you.
to reach out to me. I'll put my email in the chat as well.
Thank
Um,
you.
and yeah, so thank you. Thanks so much.
Thank you so much. I think it's been really, really
Thank
informative. And
you.
actually, I think it's an area that we don't talk about often enough. So thank you so much, Anthony, and thank you so much, Anthony, for putting us in touch with One Day, and thank you so much, One Day. So following on from that,
Thank you.
as ever, I have my mentee because we like to get feedback